All right. Well, thanks everybody for joining me today. I'm really happy to be able to share this information with you. And as Diana said, this is Gender Responsive Services for Men, and this is the first part of a two-part series on men's integrated treatment. And why don't we just go ahead and get right into it. Why would we even focus on men's services? Hasn't it all been about men since the beginning? And the answer is yes and no. The reality is while services were created by men, they were not really created with men's experience in mind. So what's been missing are services in a system that values and seeks to understand the experiences of men. So literally looking at life from a man's perspective. The impact of male socialization on service engagement and recovery. We're going to do a little exercise that's going to really show how powerful this one idea is. Relational needs of men. Actually looking at men and how we do relationships, our challenges having relationships, being in relationships, and then the needs that we have, and also what are the best way to help us gain those skills. And then most importantly, abuse and trauma. There's a horrible myth out there that says that women pretty much are the only ones who experience trauma, but there's absolutely no anecdotal evidence to support that. Abuse and trauma seem to be significant factors for men, and once we start researching this and really looking for the evidence, we'll be able to quantify what many of you already working in the field know, and that is that abuse and trauma are huge issues for men, and that we have to start dealing with them much sooner in a man's treatment process. So, so what are the rules for being a man? Well, I talked earlier about the male socialization process, and what that is that when we grow up, from the moment we're born up until this very point in our lives, as men we follow rules. We follow rules that tell us how to act, how other people expect us to act, and how we think they expect us to act. And so what are some of those rules? Well, some of those rules are always be in control. Don't cry or don't show any emotion. Don't ask for help. Be a sexual Superman. Don't show weakness, but also have integrity, responsibility, and be a provider. So it's really important that you know that they're not all negative, but there tends to be a lot of negative rules for being a man. Then there's the principles of therapy or recovery. These are the principles that when somebody is doing well in their recovery, somebody is doing well in treatment, these are the behaviors they're going to exhibit, the values they're going to project. But these are also expectations that we have as clinicians and other individuals working in the field from men. And what are those? Show vulnerability, ask for help, admit powerlessness, let go of control, be responsible, be of service, express emotion, humility, and sobriety. When you put the two side by side, you see that there's a lot of tension. There's a lot of contradiction. While not all of it is in contradiction with one another, there is a fundamental tension that's often not recognized or acknowledged in a man's recovery process, and it's also predominantly absent from the majority of treatment models for men and treatment programs. So what is men's integrated treatment? Men's integrated treatment is a form, a model of treatment that attempts to bridge some of these gaps that I've just talked about. And in doing so, it talks about male psychological development, addiction, and trauma. So the theory of addiction, without going into a lot of detail, these characteristics, these aspects of the holistic health model will probably look pretty familiar to you. The physiological, the emotional, the social, the spiritual, those are all very common when we talk about addiction. And of course, when we talk about the spiritual aspect, we're not talking about religion. We're talking more about a man's ability to recognize a power greater than himself, himself in community, a world beyond self. But there's another word, and that's the political. And the political is really about men and women, but men in particular, looking at our relationships with power, our experiences with power, and how power influences how we think of ourselves as men and how we relate to others. These are some of the things that we've learned. These are some of the fundamental changes, improvements in the field, in the practice of addiction treatment that we believe, myself and my colleagues believe, are fundamental to effective services. And that's taking into consideration the changes in brain chemistry and the impact of drugs on brain chemistry. The stages of change and understanding that people come into treatment at different periods and different places of readiness for change, and that we can't just give people the same thing to do, and when they don't do it, we blame them as opposed to not having paid attention to where they were actually at. Client-centered, strength-based, solution-oriented, all of those are aspects of treatment that really reinforce that it's a collaborative partnership between the clinician and the individual. And then, of course, managing chronic disease. And what does that mean? Well, that means that even for drug courts and any other problem-solving court, you might have them for 1.5 years or 2 years, but for chronic diseases, stabilization happens at around 3 to 5 years. If that's the case, then we need to be very realistic with our individuals, with the folks that we're working with, about what they need to do to continue taking care of themselves and not have the drug court experience or the problem-solving court experience exist within a vacuum as if their graduation means that they're done. It's really just the beginning. So what's the three-legged stool of recovery? Well, we're at a place here in 2012 where we know too much about addiction, too much about mental health, and too much about trauma that we can't separate them. They are literally a three-legged stool. If you're going to talk about addiction and you don't talk about mental health and trauma, then you can't talk effectively about that. You can't talk effectively about one of them without including the other two. And that's essentially what that means. Unfortunately, all three of those areas are still quite siloed and often attempt to do at least one without one of the others, if not both. What's strength-based treatment? Probably all of you have had training on strength-based treatment. As problem-solving courts, we're always encouraged to incorporate strength-based philosophies in treatment. The reality is it's quite challenging to do strength-based treatment. It's quite challenging to be able to stay focused on that and to not let the inherent negativity that kind of swirls around all of us to get in the way. So that's the theory of addiction. Now I'm going to talk a little bit about the theory of men's psychological development. There's evolving treatment approaches. What that means is that we're at a place where gender responsive really is hopefully going to become the norm, the expectation for services. As I mentioned, there was generic treatment many years ago where everything was from a man's perspective, or at least it was all created by men. And we tried to force women into that, leading to the gender differences, where we began to finally recognize that maybe what we were doing for men didn't work for women. Then it became gender specific, and that was special groups or services for women, but not really for men. And then gender responsive, and gender responsive again at first was applied to women, and that is trauma-informed, relational cultural theory, and it's strength-based. Now we're at a place where finally some of us are saying, you know, we've learned so much from doing these specific services for women. Is there anything we can learn for men? Is there anything we can do differently for men? And as a result of that, we're doing gender responsive services for men as well. And that's really the focus of this presentation and the presentation next week. So the theory of men's psychosocial development, really this first comment is the most critical piece, and that is the idea that men are not the problem. How men have been socialized is the problem. We have a lot of beliefs and attitudes out there that imply, especially in today's society, that there's something inherently wrong with men, that if there's something wrong in society, it's because men screwed it up. Well, I don't take that approach. I really have problems with people who do take that approach. It's not that men are the problem, it's that how men have been raised, how we've been socialized to be men, how we've been forced to follow those rules for being a man that I talked about earlier. That is the problem. Now, the consequences, the results of that problem are significant and cannot be denied and cannot be ignored. And the fallout of that are some of the things that you see below: homophobia, devaluation of women, violence, detached fathering, emotional illiteracy, power, privilege, and pain. All of those are critical to a man's experience as a man, and so therefore we say it's critical to a man's experience in recovery. And if that's the case, then it's essential that we address these issues while a man's in treatment, and not later in treatment, but right at the beginning, to really help him begin to engage in the services, but also to look at how some of these rules that he's been following are significantly impacting his life and his relationships. I talked about relational cultural theory as one of the kind of core parts of gender responsive. And what relational cultural theory says is that all humans yearn for connection. All growth occurs in connection. This came out of women challenging the traditional Western psychological paradigm and basically saying, you know what, that doesn't really work for us. And they said, you know, we tend to be very relational. And so women came together and they literally challenged the whole Western paradigm of psychology and came up with this. Now, the unfortunate thing is that as women came up with this, one of the things that happened is that as they expressed and explained the rationale for relational cultural theory, it was always this idea of, well, this is necessary because relationships are so important to women. Women value relationships so much. Women learn so much through relationships. And that while that seems to be very true, oftentimes the mostly unintended implied statement underneath all of that is that relationships aren't important to men, that men don't value relationships. And that myth, that ignorance pervades much of our society and absolutely much of the treatment system. What does that mean? It means that fundamentally, when you look at this next slide, it's not that relationships aren't important to men, it's that as a result of how men are socialized, we don't know how to do relationships very well. We know how to be agents of disconnection. That is, we know how to just kind of steamroll over things. We know how, if something's in our way, we know how to kind of get it out of our way so we can get what we want. But that doesn't leave us happy. That the consequences of that are significant. And so it's really this idea of self in relation versus individuated self. And with Stephen Bergman, who happened to be married to one of the three women who first created relational cultural theory, he looked at this for men, and this is what he came up with. And he came up with these four kind of specific identifications. One is that there really needs to be a balance between self and relation and then the individuated self, which is the traditional Western paradigm of psychology. That male relational dread, as men get closer and closer in relationships, it gets scarier and scarier for us because it actually hits at the core of our lack of relational competence. Not our relational investment, not our relational interest, but what we're actually able to do in the terms of trust and vulnerability and intimacy. And again, this idea of agents of disconnection and then power dynamics and how our need for power and how we define power and how we believe, so many of us men do, that power is going to make us men, how that gets in the way of our relationships.
You're 37 years old and worked in probation for 15 years. You liked Joey right away. You went out of your way to reach out to him. You really felt connected. He relapsed a month ago. Since then, you've found yourself more critical of Joey, even feeling resentful. A couple of teammates or team members have said, you know, you seem to be taking a pretty, hard approach with Joey. Maybe they've heard comments that you've said during staffing, but somebody points out to you that, you know, you seem to have some challenges in your relationship with Joey. So after talking to your supervisor, you realize that Joey has some similarities to your own father, who was alcoholic and died when you were in your 20s. Now, some of you may be saying, where's he going with this, or why are we talking about this? Well, here's the next question. What is the best response for this awareness about Joey's similarity to your experience with your father? And let's do this one by raising our hands. So how many of you think that the best response for this awareness would be to share it with Joey? Raise your hand. Okay, how many think it would be to ignore it? Go ahead and raise your hand. How about to find someone else to take over the supervision for Joey's case? Raise your hand if you think that's it. What about to talk to a professional therapist about your discussion with your supervisor? And of course, the last one, which is always clinically relevant, is to go to Disney World. How many of you think the answer is to go to Disney World? Raise your hand. Okay, it looks like all of you think the answer is to go to Disney World. That's interesting. That is not the answer. Of course, I'm just kidding. But the answer is that there isn't a clear answer. What I mean by that is, for sure, you'd probably want to talk to a professional therapist about your discussion with your supervisor. The most important thing is that we pay attention to what's going on with us and the reactions that we're having. And that's why your own personal awareness is so important to dealing with trauma and being able to work effectively with people. If you came from an alcoholic family, chances are you're being triggered all the time when you work in problem-solving courts. If you haven't really looked at the effect that that had on you, then it's going to come out sideways with the people that you're working with. You may ultimately find someone else to take over supervision, and you might even share it with Joey. At a certain point, it could be appropriate for you, especially from a trauma-informed perspective, to say, hey, you know, I realize since you relapsed, I've been being pretty tough on you, and I even changed the way I was dealing with you, and I think at times I was unfair. And I didn't see this at first, but I do now, and I just want you to know that I apologize for that. I was getting some things confused with your behavior and some stuff that I've experienced in the past. So I just want to say that I'm going to focus on being able to better work with you and not let that stuff get in the way. That's an amazing thing to be able to say to the people that we work with. Now, some people would say you're crossing a boundary, but I think you'd be hard-pressed to find out or to point out in what I just said where I crossed a boundary with Joey. I didn't share any of my personal information. I simply stated that this was something that my behavior and how my behavior was affecting him, and understanding that. That is something, that kind of transparency, that kind of authenticity is something that we very often don't have in our problem-solving courts. We don't have it in our treatment centers. We're not necessarily trained to be able to do that. We don't recognize oftentimes that our behavior and what we're doing reflects as much of how people are going to respond to this as anything. So let's move on from that. And if you have questions about that at the end, please feel free to bring that up again. Some of the treatment providers or problem-solving courts that use stages of change could notice that it could be lack of readiness for change. Oftentimes, particularly for men, we see it as willfulness, or we call it a lack of engagement. our first thought when somebody is acting this way is not to think of trauma. And if we do think of trauma, it's going to change everything we do with and for that man. So, a definition of trauma, and there are many definitions out there, and I actually was just involved with a meeting with SAMHSA with about 12 people from around the country to try to narrow down a definition that we can use for trauma and trauma-informed services, because there's so many definitions out there. But one of the critical pieces about trauma is understanding that it's the individual's response to the event. That there's an experience of fear, helplessness, or horror, but again, that's part of the response. What that means is that something that may be traumatic for you may not be traumatic for another person who's involved in the exact same event. That's an important piece for people to take into consideration when we think about trauma. So it's hard for us to say what's traumatic for another person. What's more important is to notice the behaviors and some of the belief systems that may be built around that experience. This is the process of trauma. This is created by Dr. Stephanie Covington, and I always, when I do work with problem-solving courts, I always recommend that they have this chart as part of what they do in their individual sessions or in their staffing. In other words, to have this chart constantly available. We're going to come back to this chart in the next presentation. But it shows a really great schematic of the process of trauma. You have the event, you have the response, then you have the actual changes in the brain, which is something that we're now much more aware of and much more informed about. You have the current stress that can then remind somebody of the traumatic experience and not consciously remind them. And then there's a painful emotional state, and then there's the actual behavior that happens as a result. The impact of trauma is extremely pervasive. You know, sometimes we tend to see it as behavioral, but there's a biological impact, how it affects our body, how it affects our cognition and our ability to think, psychological, regulations of our emotions, and our perceptions, which obviously affects our relationships, which is also the social component of it. How do we relate to other people? How do we engage in relationships? How do we disconnect or disengage from relationships? The social piece is also just in general about community. How do we engage in community? What are the behaviors that we show and how we interact with others? And then, of course, relational. And trauma really comes out the most in our closest relationships. And that is what can make trauma all the more difficult to deal with, particularly because it gets hooked in to a lot of other issues, such as domestic violence and other kind of problems that couples or close relationships may experience. So we've already talked about how the trauma is the individual's response, but then it's the idea that there's a maladaptive behaviors and beliefs that happen as a result of that. And what does that mean? That the behaviors that actually were not maladaptive when they first developed, these are the things that actually helped the individual to survive the experience. But later, as they move into or functioning in a healthier environment, they find that those behaviors don't work for them anymore, but yet they have a very difficult time not engaging in those behaviors. And oftentimes it's because of the beliefs that underlie those behaviors that have been so strongly rooted. This is particularly for young children who've experienced trauma. Their brains are just developing. They can easily get the belief system created out of those experiences. Children don't have the ability to separate and say, oh, okay, my father's beating me because he's an alcoholic and because he can't regulate his emotions. My father's beating me because there's something wrong with me. Those beliefs then begin to pervade the individual's life and can often even set them up for additional trauma. Traumatic stigmatization, that's another important part of all of this. And what is that? What that simply means is that there are those who come from particular backgrounds that have particular characteristics or experiences that place them in an area of marginalization in society, that they have aspects of who they are that are not honored in society, that are marginalized, that are demonized, that are any of the negative ways that people respond to those characteristics. So that can be generational. We talk about that a lot with African American community and the impact of slavery, or the Native American, American Indian community, and the impact of many of the things that have been done to them over the years, most recently, of course, with the so-called educational schools. So keeping these things in mind is extremely important, but again, it's important not to impose trauma onto an individual. They may have some of these characteristics. They may have one or multiple. It doesn't mean that they've got trauma. They could have been in a very healthy environment that helped them to process that component. Their response to it could have been one that really empowered them and helped them to deal more effectively with it. So it's important to keep these in mind, as it is any kind of experience that we learn about from an individual, but to not simply impose the idea or the experience of trauma, the diagnosis of trauma, as a result of what we learn about the individual. So universal precautions. What are universal precautions? Well, if you think about in the late 80s, early 90s, as the AIDS epidemic was really spreading across the country, across the world, there was a determination that anybody coming in through into services, addiction, mental health, should be treated as though they could possibly have HIV or AIDS. And that was simply to protect the people working with them and other individuals from getting the virus. Now, obviously, we've learned some things about that, but the idea of universal precautions as it relates to trauma simply says that we should assume every person, every man, every woman walking through our doors has had trauma. That doesn't mean, again, that we impose a trauma diagnosis on them, but what it does mean is that we create environments, we train our staff, we interact with people with the idea in mind that they've experienced trauma. As we continue to work with them, we'll begin to better understand, better assess their experiences, and then we'll be able to really understand who may have a more severe or chronic trauma history, who might have some kind of acute trauma history, and then who may not have a trauma history. But when we use universal precautions, it really enables us to be thinking constantly about trauma so that we're not re-traumatizing individuals. Even if only 1 out of 12 men in your services has had trauma, if you are using universal precautions, you're much less likely to re-traumatize that man, trigger him, and then ultimately kick him out for traumatizing him or triggering him. Many treatment failures may very well have been unresolved trauma disorders. And I'm going to do a piece of the presentation next week that will make this even more clear. So what can happen with undiagnosed and untreated trauma? Well, we'll see a lot of people return to the use of alcohol and other drugs. What does that mean? Well, that means a lot of the times when people relapse in our courts, in our programs, you know, It could be very well that they're relapsing just to try to deal with the trauma that we've missed, the trauma that had we been better trained or better informed, we would have been able to catch, and that it wasn't just because they weren't engaged in treatment. It wasn't just because they didn't get the skills, but literally because being triggered to the extent that they were, it literally created this non-cognitive reaction and response that led them to use again. And then, of course, there's the continued abusive, violent, self-destructive, and even criminal behavior that can continue long into an individual's sobriety. You know, maybe they get arrested for a crime, maybe they don't get arrested for a crime, but how are they behaving? How are they interacting with others? What are their relationships like? What are they doing in their behaviors? As a person also in recovery, I've seen over the years so many men in the recovery community, 5 years of sobriety, 10 years of sobriety, 15 years of sobriety, who have a lot of undiagnosed, untreated trauma, and they're on their third marriage because they can't really connect in a relationship or deal with the conflict, or that they may still be on their first marriage, but they're engaged in very abusive behavior, or maybe they just really don't know how to develop close relationships. There's so many ways that men's trauma affects a man's recovery, and that's really one of the big instigators for why I do the work that I do. Having been in the community for a while and having seen it, it just makes complete sense that if we started talking about it, working with it, and treating it sooner, a lot sooner, as in when people are first coming into services, we could spare a lot of men from a lot of pain. And that would mean sparing a lot of women, children, and other men from a lot of pain that those men may also be causing. 42 to 95% of men coming into treatment could have trauma. Why is that number so disparate? Well, because we've done a horrible job, quite frankly, of assessing and recognizing men's trauma. It's really been very unfortunate, in particular male sexual abuse, but trauma in general. Men experience trauma differently than women do, and a lot of men come to accept trauma or the experiences that have developed trauma for them as things that either they deserved or as things that were just part of literally being raised as men. 90% of male sexual abuse survivors did not report the abuse until they were adults. What does that say? Well, that says that if you think of sexual abuse, it's really one of the toughest things for men to talk about, particularly if it's sexual abuse from another man. So until the effects of that has really significantly impacted a man's life, he very well may not come forward about it. But a lot of men don't come forward about it. We don't learn about it because we're not asking them about it. Or if we are asking them about it, it's when they first come into our services, we do an assessment after knowing them for 10 minutes, and we say, were you ever emotionally abused? No. Were you ever verbally abused? No. Were you ever physically abused? No. Were you ever sexually abused? No. And then that becomes basically their history and how we treat the rest of their treatment process. So we know that there's much higher incidence of male sexual abuse than we thought. At least 1 in 6 men in the general population have had sexual abuse. So when you think of your populations in the courts, we're probably looking at anywhere from 2 to 4 out of 6 men being survivors of sexual abuse, particularly when we begin to redefine sexual abuse, when men come to see that having sex when they're in 6th grade with their teacher was not a rite of passage, but was sexual abuse and was something that has probably had a very serious effect on them. So here's the main piece of what we're talking about when we talk about gender-responsive services for men, and particularly being trauma-informed. It's moving from this idea that something is wrong with you, what is wrong with you, to asking what happened to you. Our services, the criminal justice system, the court system, our society in general is really predicated on this idea that there's something wrong with you, there's something wrong with us, there's something wrong with me. At the heart of that are tons and tons of different behaviors and beliefs and perceptions about people. However, when those ideas are embedded in the services we provide, particularly for trauma survivors, it reinforces their trauma and often leads to increased silence and increased secrecy. But when we begin to ask what happened to you, not in the space of what happened to you so we can excuse your behavior, but what happened to you so we can better support you, so we can better understand your story, well, then that transforms the whole process and everything for men. So I wanted to be sure to leave some time for questions. If you have questions, you can ask them. You'll see in your control panel a place where you can enter the question, and then I'll see it, and I'll respond. And this is my contact information. If you don't want to ask the question now, or if it comes up for you later, feel free to contact me. And again, I really appreciated the opportunity to do this presentation, and appreciate you folks taking time out of your busy schedules to listen as well. I see a question, but I can't quite. I'd like a copy of the trauma. Oh, sure. Just email me, and I'll send you a PDF of the trauma chart. The other thing that I can do is talk with NDRI, and if they're going to be making these slides available, I can just send them the chart, and so they can have that available as well. Okay, well, thanks again, everybody, and appreciate you tuning in. Don't hesitate to contact me if you have additional questions or thoughts. I am available for technical assistance. I'm available to come to your court and do trainings. And we do have a curriculum that I'll be talking more about next week that we've developed that really is the first gender-responsive curriculum for men. And we incorporate those ideas into the work that we're doing. And I want to just see this comment, not a question, but a comment. I've given your 12-step for men book to a few friends in the program. Just want you to know that they love it. Well, thank you very much, Lori, for saying that. It really was a passion. It really is a passion of mine, and really came from my heart. And I'm really glad to see that men and women are getting things out of this work. And that's an important thing to remember, that just as men have learned so much from the gender-responsive ways that we do services for women, women are learning so much about the ways we do gender-responsive services for men. In particular, you know, a question that often comes up is, well, what do you think about women working with men? And what I will say to that is, one, I think it's absolutely fine, but the other is a very pragmatic answer, a realistic answer, and that is 70% of the people coming through services are men, and 70% of the people working in services are women. So really what's incumbent upon the field and incumbent upon us as trainers is to ensure that women are appropriately and properly trained to work with men. Despite some women's belief, there's not an inherent understanding of men if you're a female. And I say that, you know, mostly in jest, but we have to start getting this kind of training out there for working with men. So thanks again, everybody. And I think what we're going to do is, if there's no other questions, and I'll wait about 30 seconds for another question or comment. But if there's no other questions, then we'll go ahead and end the program. There is a survey, too, that you're going to get. Please take the time to fill out the survey. It's really important feedback that you can give us as presenters, but also that you can give to the folks who organized this presentation and this training. All right, well, thanks, everybody. We're going to go ahead and close the presentation then.